Good afternoon, everyone, and welcome to the Lowering the Risk of Suicide During the Pandemic presentation with Dr. Michael Anestis, brought to you by the Gun Violence Research Center at Rutgers and the Rutgers University Alumni Association. Thank you so much for taking the time out of your day today to join us. My name is Katie Mayfield, and I'm the Director of Development for the Rutgers School of Public Health, which is where the Gun Violence Research Center is housed at Rutgers. I hope that you and your loved ones are safe and healthy today. Before we get started with today's program, I wanted to take time to acknowledge the current moment in America. And I'm going to do that by reading a statement or part of a statement issued from the Dean of the Rutgers School of Public Health, Dr. Perry Halkitis. The health disparities associated with the COVID-19 pandemic, coupled with the ongoing policing and brutal killing of Black and Brown individuals in our country, point to the reprehensible systematic racism that continues to run rampant in our society. At the Rutgers School of Public Health, we know that racism and all forms of discrimination are public health crises that must be addressed in order to tackle pressing public health issues like the current pandemic, end quote. During this time, the Rutgers University Alumni Association is expanding its offering of virtual programming to highlight the important work being done at the university and to help keep our alumni and all of us more connected. So today we are honored to have with us the incoming Executive Director of the Center on Gun Violence Research at Rutgers, Dr. Michael Anestis. Dr. Mike Anestis is currently an Associate Professor of Psychology at the University of Southern Mississippi. As of July 15th, however, he will join Rutgers as an Associate Professor of Urban and Global Public Health and as the Executive Director of the New Jersey Center on Gun Violence Research. Dr. Anestis' research focuses on suicide prevention with a particular emphasis on the military and the role of firearms. His work has resulted in approximately 150 peer-reviewed scientific publications, along with the book Guns and Suicide: An American Epidemic, released by Oxford University Press in 2018. Dr. Anestis was the 2018 recipient of the Edwin Schneidman Award from the American Association of Suicidology, given in recognition of early career achievement in suicide research. He is excited to be moving to New Jersey in 2 weeks and finally being close to his family in Connecticut after 15 years away. It is now my distinct privilege to turn it over to Dr. Michael Anestis. And before I do, just a reminder that the question and answer feature is at the bottom right-hand corner of your screen. As questions arise during the presentation, please type away in there, and I will be doing that in the second half of the presentation, the question and answers. Take it away, Dr. Anestis.
All right. Thank you, Katie. And thank you to everybody for taking your time out of your day to come and talk about this topic, which is sort of near and dear to my heart. It's a difficult one to talk about, but one that I think is really important. So I really appreciate you being willing to carve out a portion of your day to hear me yap about a little bit, but then hopefully to submit some questions that we can go back and forth on today. And hold on, I'm trying to get my slides, of course, which we're working before. There we go. Okay, so as Katie said, I'm going to be talking about lowering risk for suicide during the current pandemic that we are experiencing. Part of what I'm going to talk about today is going to be suicide risk in general. And then throughout portions of what I'm going to talk about, we'll sort of pause and ask some questions about how is what I'm talking about specifically influenced by what we as a world really are going through right now with COVID-19. I want to make sure that as we go through this, I'm going to reiterate this a few times, I don't want this to come across as alarmist. And so the point of my talk isn't to say that we are doomed to a surge of suicides. It's just going to point out that, there's some risk we need to be aware of. But fortunately, I think there's some tools available to us that if we're willing to talk about this and follow the data, there's a lot of things we can do to protect ourselves from having even more sort of bad outcomes associated with what we've been going through. Before I get going, I do have to take a second to note that some of the work I'm going to talk about was funded by a group called the Military Suicide Research Consortium, which in turn is funded by the Department of Defense. So any opinions that I express today, either during the talk or during Q&A, those are mine and not necessarily from the DoD or MSRC. So I give a lot of talks on this topic, and being that I have this role with the GVRC and the focus of my work is firearms, a lot of what I'm going to talk about today with respect to suicide is firearm related. And I learned very early on in my time in this part of the field that it's important to be upfront about who you are and what you're trying to do early on in a talk about this topic, because I think a lot of folks come to the room, or in this case, log online, with their own experiences and opinions about firearms, and if folks come in with a sense of what I'm going to say and they're not happy with that, I think it can sort of derail things quickly. And so I like to put all cards on the table and just sort of be upfront about who I am and what it is I'm trying to do. And so for every talk on this topic, I try to lead off with this idea of what am I not here to do and what am I here to do. And what I'm not here to do, first of all, is vilify firearm owners. I certainly have opinions about firearms, and I'm sure you do too. And I suspect many of us in this webinar disagree on the topic, but the bottom line is that's okay. This isn't a talk focused on criticizing individuals. It's about recognizing where there's risk and what we can do to lower that risk. I'm also not here to come in and say if all the folks in the webinar have the most experience with firearms. I definitely don't. I have more than zero, but not a whole heck of a lot more. And so a good way to sort of destroy your credibility is to pretend to be something different than you are, and that's not who I am. I'm also not here to claim that means safety, which is something I'm going to explain in just a little bit and talk about quite a bit. I'm not here to say that this solution I'm going to talk about will get rid of suicide for everyone forever. Not at all. I'm going to say that we have a tool that's available to us. It's very straightforward, that respects a whole lot of different cultures, and that can produce some really meaningful results. But that even if we do that to the best of our ability, that's not going to completely get rid of the problem. So what am I here to do? I am going to talk about suicide in general, both sort of in the years that preceded this and that'll come, and also in the current moment of COVID-19. But I'm going to zero in on firearms quite a bit. I'm going to do this from a very non-emotional, data-driven perspective. We can talk about a difficult issue in a way that isn't going to put people off. I'm also going to argue that I think we can leverage the knowledge that I have, that other folks have in this sort of niche area, to offer a solution that I think would result in really substantial and sustainable reductions in the national suicide rate, which to me is a really good cause to pursue. And so hopefully we come out of this conversation with an idea of steps we can take to make a real difference going forward on this issue. So I think it's important to lead off any discussion of suicide with a discussion of the basics, just some of the numbers. Some of you probably come to this webinar with a real clear understanding of how big this problem is and who's most affected and why. But for a lot of you, that might not be the case, and that's okay. This is a topic that we don't often talk about in the media, even in private conversations. Is a difficult one, and unfortunately, when you talk about things often, that results a lot of times in folks not having a general sense really of how big a problem something is or what that problem looks like. And so let's start with some of the basics. 2018 is the most recent year that we have official CDC data on suicide deaths, and in that year, over 48,000 Americans died by suicide. So that's the 10th leading cause of death in the entire country. You're looking at basically one out of every 10 minutes, somebody in the United States is dying by suicide. And for every one of those deaths, there are about 25 non-lethal attempts. So 25 times somebody attempted suicide and didn't die for every one of those 48,000 plus deaths. So in a lot of ways, this is what we call a low base rate problem. Most people don't have experience with this, and yet those are some really, really big numbers. It's a problem worth talking about. On the firearm side of things, just over half of those suicide deaths resulted from that single method. So over 24,000 Americans died by suicide using a firearm in 2018 just by one method. And that's true even though firearms were used in less than 5% of all the suicide attempts in the country that year. So folks almost never use a firearm in a suicide attempt. And yet if an American dies by suicide, more often than not, they use that method. So that tells you, yeah, this is a big deal. This is an aspect of suicide that we need to talk about clearly and on its own, and not just in the context of other risk factors. I also want to point out with that figure down below that graph, I'm not cherry picking a number to make it sound like this is often a big deal. This is always how it looks. The suicide rate in this country has gone up over 30% since the turn of the century. It's gone up every single year since 2005. And in every single one of those years, the firearm suicide rate has been right at or right below or right above 50% of the overall suicide rate. So this is the standard American story from year to year to year, not just in the most recent year. Unfortunately, though, even though the scope of this problem is huge, we just don't talk about very much. And so a lot of people are surprised to find that compared to things like auto fatalities and homicide, which you hear about in the news or you talk about with peers far more often, suicide actually dwarfs those causes of death in terms of raw frequency. And so a lot of folks are impacted by this, but because of the lack of communication and because the communication we do have on this is often so far removed from the actual data and the actual science of this, people are often left thinking this is a much rarer or distant phenomenon. This is something that happens to other people, not to me and not to my loved ones. And it's very easy to sustain that narrative when we don't sort of make the effort to put it in the forefront of our conversations. So just a couple other slides where I want to set the basics of sort of what is the problem of suicide and who's most impacted. And then I want to start to zero in a little bit more about why this happens. And so one of the most important things to understand in suicide is the sex differences that stand out. And so in the US, about 75 to 80%, or sort of 3/4 to 4 out of 5 suicide attempts in this country are by women. And yet, despite that, 75 to 80% of all the suicide deaths in this country are by men. So the vast majority of suicide attempts are by one group, and the vast majority of suicide deaths are by a different group, right? And so when you're thinking about understanding what suicide is and how it works, I would argue you need to have sort of a framework, a theory that not just kind of explains that away after the fact, but anticipates that this, of course, is exactly how that would work. And I'm going to present a framework like that in a minute that hopefully sort of clarifies why this might be. But the simplest answer is that this is in large part a function of how people choose to attempt suicide. And so 2 out of every 3 suicide deaths by men in this country are by firearms, but only 1 out of 3 suicide attempts by females are by firearms. And so you have a different choice in method, which might not sound like it matters, except how deadly the methods are is very different. And so for men, the fact that they choose firearms more often matters because 85 to 95% of the time somebody attempts suicide using a firearm, they die. And that's fundamentally different than other methods. By far the most common suicide attempt method in this country is intentional overdose. That only results in death 2 to 3% of the time. So when someone attempts using an overdose, almost always folks survive. When someone attempts using a firearm, almost always those folks die. And so if folks are choosing different methods, they are going to die at a much different rate, which tells you, yes, we need to focus in on why people are upset and we need to help them feel better, but we also need to focus in on what methods people are choosing, because that decision right there has an enormous impact on the outcome of their suicide attempt. And all of this is brought into the forefront is important, even more so when you consider what I believe is the scariest study I've ever encountered, published by a guy named Joe Franklin a few years ago, where he found that we are actually no better at prospectively predicting death by suicide than we were in the 1950s. The best experts are slightly above a coin flip. And so if you think about how we go about trying to prevent suicide, we generally find folks who say, hey, I'm in agony, I'm upset, I need help. And we try to direct them to the best care available to make them feel better and not want to die by suicide anymore. And there's nothing wrong with doing that. In fact, we should do more of that than we do. That's life-saving work. But if we're actually not any good at knowing ahead of time who's going to die by suicide, when we have a system that relies on identifying that risk ahead of time, we're going to be in a lot of trouble. So again, you think back that figure I showed you, the suicide rate keeps going up and up and up, even though our tools for preventing suicide keep getting better and better. That's a sign that we're going about this incorrectly, and that in fact we're making a lot of guesses that just aren't hidden very often. And so again, I circle back to method. So I'm coming to you live right now from South Mississippi, where I'm living for a couple more weeks. And the story of suicide in Mississippi is one about firearms. Just about 7 out of every 10 suicide deaths in the state that I'm in right now result from this same method. And if you zero in on particularly high risk groups for suicide, so let's say older men, you're looking at around 95%. So almost all the suicide deaths come this same method. If we step out of the state of Mississippi and look at sort of a high risk group spread across the country, so service members, about 2 out of every 3 suicide deaths amongst U.S. service members result from firearms too. So you've got these clusters of particularly high-risk groups, whether you're talking about geographically bound groups or culturally bound groups like the military, that are especially prone to using specific methods that are really likely to cause their death if they use them, which again helps us figure out, well, where do we need to direct some of our resources, and how can we best motivate people to change their behavior? So sort of wrapping up my section on what is suicide and how does it work, I think the most important phenomenon to understand about suicide, and one that we as a country, I think, often fundamentally misunderstand, is that suicide isn't easy. It's not this simple thing or the coward's way out. It's really quite different than that. And it's reflected in this graphic I have here in this slide, which highlights the idea that the vast, vast majority of folks who think about suicide will never attempt suicide. And the vast, vast majority of those who attempt suicide will never die. And what's important about that is that all the factors that you can likely think about that you think would cause someone to be most likely to die by suicide, poverty or depression or loneliness or substance use or abuse victimization, so many things that absolutely are devastating and play a role in this, they actually don't tell you anything about who moves from thinking about to attempting to die in suicide. They tell us who's in agony. They tell us who's going to be most likely to think about it. But if you get a group of people together, all of whom are thinking about suicide, none of those risk factors tell us anything about who's going to act on it. And of those who are going to act on it, who's going to use a method most likely to actually kill them? And that's obviously an extremely important question. The ideal outcome in suicide prevention is not just that you keep someone alive, but that they're living a life that is thriving and they're happy and they've identified their values and they're living by those values. But in order for any of that to happen, I need them to be alive. And so I need to better understand what makes someone move along this continuum from thinking about to trying to dying. And if I can't do that, then I don't know how to prevent this behavior. I don't know how to intervene ahead of time. And so this is why so often the story after an American suicide is, I never saw this coming. One of the things that folks tend to focus in on is mental illness, and there's nothing wrong with talking about that. But there was an enormous epidemiological study called the National Comorbidity Survey, where they gave folks a huge sample of folks, a massive number of questions, and then 10 years later asked them the same things. And what they found was that no mental illness, no number of mental illnesses, and no combination of mental illnesses predicted who attempted or died by suicide during those 10 years. They told us a lot about who thought about it, but again, like I've been saying, it told us nothing about who actually acted on it. And so the idea is the way we've been thinking about suicide is wrong. We've been missing what it is that causes folks to actually move along that continuum of risk. And so the theories that have come out about suicide are what a lot of us refer to as ideation to action theories that tell us not just about who's going to think about it, but who's going to act on those thoughts. And the one that influences me the most, and I'm going to sort of thread throughout this talk, is by a guy named Thomas Joyner, and it's his interpersonal theory of suicide. And this theory says some things that a lot of you guys probably already think and know, and one particular thing I think that is unique and sort of a real shift in how we think about this stuff. And so the stuff that's more common is the idea that in order to die by suicide, obviously folks need to want to die. And Joyner argues there's a couple of things that go into that, this idea of perceived burdensomeness. So I'm a burden on the world. My death would be worth more than my life. And then thwarted belongingness, this idea that I'm alone. I don't have these reciprocal relationships that make me feel connected. And if you're feeling those things and you feel hopeless that that's going to change, Joyner argues that, well, then you're much more likely to desire suicide. But like I said, most folks who think about this or want this don't attempt. And that's because Joyner argues this unique thing, which is that you actually have to also be capable of it. And I'll talk about each of these things more in a second, but the idea of capability is that suicide is hard and there's a genetic imperative to survive. This is why you can't fill a sink, stick your head in it and drown. You will lift your head. There is a imperative for the survival of our species that it'd be difficult for agony to turn into death. If it wasn't, we would not survive as much as we have, right? And so Most people, Joyner argues, who want to die by suicide can't. And similarly, most people who can don't want to. Where risk is really high, where people make that transition, is if they both want to and they're able to. And so we'll talk about some factors that can play into that, but a lot of the things you probably think about, hopelessness, loneliness, isolation, these things prompt people to feel agony. But it's also important to note that no single individual story is the same as anyone else's. So when I talk about theories and what makes someone at risk, what I don't want to do is invalidate anybody's specific path or story. That's not the idea. Everybody is unique, and not everybody's story is going to line up with the leading theory, and that's okay. The theory isn't really trying to tell what everybody's life story was like. It's trying to position us to save as many lives as possible without diminishing the value of the fact that everybody is their own unique individual. And so these ideas I talked about, perceived burdensomeness, this is again this idea that people in my life would be better off if I were gone. And so you can see this amongst folks who maybe have been fired or have become physically impaired. They come to believe that they're just a drain on society. What's important, though, is that this is a perception and a misperception on the part of the suicidal individual. The folks who die by suicide are not just liabilities in society, and the world doesn't get better because they've gone. But that's the lens through which they are looking, and that's what they are feeling, and they're convinced is true. By the same token, this idea of thwarted belongingness, I don't feel connected to anyone. That could be as simple as nobody loves me, but it could also be with a service member, for example, coming back from a combat deployment, who's now home with their spouse and children. They can say, yes, I know these people love me, but they have not seen what I've seen. There's a disconnect. I feel distant from them. And the reality is we're an extremely social species, and when you fray those connections, a lot of problems emerge. But here again, it's a perception on the part of the suicidal person. The folks who die by suicide are not unloved pariahs. In fact, there's amazing work by a woman named Julie Searle showing that up to 165 people consider themselves loss survivors for every death by suicide. 165 people say, I felt that loss. And so obviously the numbers tell us, no, these folks are not lacking connection, but they themselves feel it, and that's what matters. It's not the reality from other people's views. It's the reality from the view of the suicidal person. And here again, this is why so many people say, I never saw it coming, because how we view people isn't how they view themselves. So what about during the pandemic? Are there things that make people more at risk of feeling these things? I mean, the short answer is I don't really know. We can't say for sure. I think a lot of folks are jumping to some conclusions that may turn out to be true. But again, I want to avoid being alarmist. In the absence of data showing something is true, I don't want to assume it is just because it's intuitively appealing, right? But I think there's reason for concern, reason for us to be proactive. And so you can think about things like social distancing. That's an extremely vital life-saving tool, and I would never argue against it. But you could also see situations where social distancing has caused increases in isolation for some folks. And isolation sounds a little bit like that thwarted belongingness idea I was talking about a minute ago. And so there's some concern there. Now, the counter to that is maybe folks are connecting via technology. I hear from people say, oh, I've been having, happy hours with friends I haven't talked to in 20 years because of this. Great, that's wonderful. And for those folks, maybe this has actually increased their connectivity. But I don't know that that's really the story for everyone else. And so that's an idea that has me a little bit antsy, right? That if people are feeling isolated alone more than they were before, well, that's a risk. That's something that's going to make people feel worse. And when people are feeling worse, that sort of sends off some alarm bells for me. You can also think just more logistically. There's financial insecurity, occupational insecurity, and housing insecurity that have increased during the pandemic, right? And all of those variables are associated with increased risk for feeling suicidal. And they can tie into that belongingness or that burdensomeness or both at the same time. And so again, when people are experiencing these difficulties, risk goes up. And we want to be proactive and think, what can we do either on an individual level or systemically to reduce risk amongst folks who are most impacted by the situation in front of us? And along those lines, that highlights the fact that disparities that are already in place ahead of the pandemic have been increased for groups who are underserved, who are living in the shadows, and are more heavily impacted by COVID-19. Well, that risk gets even further amplified. And so there are folks who are often left out of the national conversation about suicide or about other topics. And I worry about them, and I worry about our country's focus on addressing those gaps in access to care and in connection to resources. There's also just logistically, over 100,000 Americans have died in the last few months that we wouldn't have expected to. And that's resulted in a lot of people losing loved ones. And losing loved ones is in and of itself also a source of risk. And so we have a lot of folks who are experiencing loss and mourning. And the most normal experience of mourning is absolutely normative sadness that passes. But for some folks, that's not how that is. And so, yes, I have concerns there as well. And so I want to highlight again, an increased suicide rate is not inevitable. And the total effect of this is going to be unknown for years. But sure, there are reasons for concerns. And so I'm going to talk about things we can do to address that. But what about this capability idea I was talking about? Well, that involves the ability to act on suicidal thoughts. This is a hard thing to do. Again, that's why most people don't do it, even when they want nothing more. And so what folks argue about this idea is that to be capable of suicide, you need to have elevated tolerance of physical pain, because suicide can be painful. You need to have diminished fear of death and bodily harm. There are things that most of us cringe and cannot do for good reason, and that protects us, but other people can't approach those things. And then logistically, there's access to and comfort with lethal methods for suicide, like firearms, and that's what we would call practical capability for suicide. So has the pandemic made people more capable of suicide? Here I have a little bit more certainty in terms of my concern, and it's specifically focused on firearms. So if you look at NICS background check data from February, March of this year, 1.8 million people approximately more than last year bought firearms during that stretch, right? And so a huge surge in firearm sales, including presumably a lot of first-time firearm owners who may not have a lot of experience with them or knowledge about safety. There's also the week of March 16th to the 22nd of this year, which was the single largest number of NICS background checks since the system was created more than 20 years ago. And so a true surge in firearm access. And as I noted, access to and comfort the lethal means is a factor that can help somebody act on suicidal thoughts. And so, yeah, I do have some concerns that the pandemic has made people more capable of suicide. That doesn't mean they're more suicidal, it just means that they're having suicidal thoughts. I'm more concerned about what they can do about that. So it's important to know that these things are related, but knowing the two things sort of dance together doesn't tell you how or why they do that. And so it doesn't give you a lot of tools to fix the problem. And so let's take a couple of minutes here to quickly talk through why these things are related. And again, with my GVRC position and where most of my research is in, we focus on firearms a lot in the talks that I do. That doesn't mean this is the only source of risk, obviously, but it's one that I think is really important and probably the most important conversation for us to have in terms of suicide prevention. And so a few basic facts that are worth knowing is that suicide is up to 5 times more common in homes that have firearms compared to those that don't. And that risk goes up substantially higher if they're stored unsafely. It's important to note, though, that when I say store firearms safely from a suicide prevention perspective, I'm saying store the firearm unloaded, separate from ammunition, in a locked location like a gun safe or a lockbox. But if you speak to a firearm owner, as I often do in the work that I do, they think of firearm safety sometimes differently. And so it's important to be clear what you mean. A lot of folks are trained to think of firearm safety as having one loaded on the ready, maybe in a bedside table or under a pillow in case of home invasion. And so it's important to know when I'm encouraging safe storage from my perspective, what I'm arguing can feel counterintuitive to the folks I'm speaking to, because by definition, if they think to be safe, you have to have one on the ready, and I'm saying have them unloaded and locked up, I'm in a lot of ways asking them to make their house feel less secure, make them less capable of protecting themselves and their family. And so it's important to have conversations that acknowledge the perspective of the person you're speaking to and doesn't just lecture at them about what they have to do. Because if you do that and you sort of invalidate the viewpoint of the person you're trying to reach, you are not going to reach them. You're just going to state your perspective. And I don't think that's our goal here. So where do firearms fit in this Joyner theory of suicide? It's in the capability. Owning a firearm, having access to a firearm, does not make someone suicidal, but it makes a suicidal person more likely to die. And like I said earlier from Joe Franklin's study, we often don't know who's most likely to die. And so what that means is there's a lot of folks out there who aren't engaging with our mental health system, aren't telling us they're suicidal, but they are. And they have firearms and they're stored in safely. And because I don't know they're suicidal, I can't direct them to resources, and I can't convince them to engage with resources that make them feel better, which means I might need to do something that makes them less capable of acting on those thoughts if they have them and I don't know about them. And that's where a lot of what I'm going to talk about today about safe firearm storage comes into play, how to keep people safe if we don't even know if they're at risk. So really quickly, being a scientist, I like to make sure there's a little bit of data to back up what I'm talking about, but I also want to be mindful of time because I'd like to leave 15 minutes or so to just chat. And so I'm going to talk through a few studies really quickly just to make sure you have a sense that I'm not just saying things that lack any data behind them. And so one study I published with my colleague Dan Capron at USM a few years ago, we had a small sample of community members from South Mississippi, and we just wanted to look at, well, how much experience you have with a firearm related to capability for suicide? Because if that's what this theory argues, we should be able to show that. And in fact, we did find that how much experience somebody has firing a firearm was associated with their fearlessness about death, about their physiological pain tolerance and pain persistence, in this case, pressure pain administered to their fingers, also their lifetime history of suicide attempts. So all these things that map onto this idea of capability of suicide I was talking about. But importantly, it was not related to the suicidal thought. So again, using a firearm, having access to it, doesn't make someone suicidal. That's not its role here. But it makes a suicidal person more capable of acting upon those thoughts if they're there. Another study I published with one of my graduate students, Claire Houtsma, a couple years ago, sort of builds off research that folks like Matt Miller have been doing for years, and just sort of combined a lot of their studies so that people couldn't make accusations of cherry picking one thing or another. And so when you talk about firearms being related to suicide, a lot of times folks will say, well, yeah, but what about these things that are more important, like depression or all these other problems that are making someone feel upset? It's not an unreasonable question. And so what we did was say, well, let's consider all these things together. So we looked at what percentage of the state owns firearms was related to the suicide rate for that state. But we said, first, before we consider that, let's also factor in education and race and age and population density and religiosity and poverty and veteran status and mean elevation above sea level, which for reasons I won't get into now are really highly correlated with the suicide rate at the state level. We looked at drug and alcohol use, mental illness, suicidal thoughts, depression, and many of those things mattered, but they didn't wipe away the effect of owning firearms. And so what we found was, yeah, the higher the percentage of the state that owns firearms, the higher the suicide rate, even when we consider the effects of how depressed that state is or how economically struggling that state is. All those things are important too, but firearms are their own unique risk that we have to talk about. And then one other one I published recently with my colleague Craig Bryan and others at the National Center for Veteran Studies, and a huge sample of service members in primary care. And we found that suicidal service members were less likely to have a firearm at home, which is good news. But among if you look at suicidal service members who did have a firearm at home, they were more likely than anyone else to store their firearms unsafely, in this case, loaded and in a non-secure location, like a bedside table. And so what that tells us is the folks at greatest risk suicidal with a firearm at home are the ones most likely to store them unsafely, most likely to have ready access. That's not good, because those folks who are suicidal and they own firearms are more likely to use firearms in a suicide attempt, and that they can get to them easily. There's not a whole lot we can do to intervene. So what do? I want to call attention for a second to the infographic on the right side of the slide that was put together by my graduate students, particularly Ali Bond and Sam Darawala. And I won't go into the details of it right now, but I will say it is freely available from my Twitter feed, which you'll see at the end here, through an article that Ali and I put on nj.com. So this is a really quick, easy, digestible summary of why is risk there and what can you do. And we're doing more of these and making them freely available. So feel free to please save those, disseminate them. We don't make any money off them or anything. It's just we're trying to create resources for folks to understand this. So what do? Well, first of all, separate from firearms, what do we do about people feeling upset in these moments? Well, what you want to do is try and create connections, right? So social distancing, as I said earlier, creates some complications for loneliness. It can make it more likely folks are isolated. So what do? What if folks can't go in to see their mental health service provider? They don't have one, or they don't want to. Well, there's telehealth, so it increases privacy. A lot of folks who are at risk for suicide don't want to talk about their problems, or certainly don't want to do it in a situation where anyone's going to know that they're doing that. There's a lot of stigma. There's a lot of social and logistical obstacles to people doing these things, and so telehealth can get past some of that. There's also smartphone apps that offer supreme anonymity to people to get help. And you can see Virtual Hope Box up there in the top corner of the slide. That is an evidence-based suicide prevention app available on smartphones, mostly tested among service members and veterans, but not only amongst them. Very simple, straightforward, and the kind of thing someone can manage on their own if they're not comfortable engaging with the system. I would also argue that we need to increase the delivery of interventions, even just straightforward, simple interventions, by community members. We need trusted voices. If folks don't want to talk to healthcare providers about their suicidal thoughts, maybe there are other people they do want to talk to, faith leaders, educators, anyone throughout the community who's a trusted voice, who has frequent contact with the folks most likely to die by suicide. We need to work with communities and empower them to speak directly to people who are at risk and not simply rely upon the healthcare system. And again, that's not to demean or diminish the role of the healthcare system. I want to provide more resources for them to do what they do, but we cannot rely solely upon them, particularly in a time of social distancing. There are complications, though. As I suggest all these things, if people are using smartphone apps, are those evidence-based, or did someone just throw something together and pitch it as suicide prevention? Because that's dangerous. Just because you think something will work doesn't mean that it will. Are underserved groups able to access these tools? And if they are their perspectives represented, or is this an intervention voiced by someone who sees the world fundamentally different and who does not sound credible and does not speak sort of lived experience of the folks who need that intervention? So we need to make sure that we're providing tools that map onto the needs of the many communities who are at risk for suicide, both now and just in general outside of the pandemic. And so there's a lot of things we need to keep in mind as we go forward. It's not as simple as we'll just throw things online and it'll be fine. We need to hear from the communities, and we need to adapt in a way that is both data-driven and representative of the folks in need. What about firearms? Well, keep in mind, as I said before, that the tools we have, they're getting better, and yet our suicide rate's going up in large part because they aren't reaching the people who need them. And so the folks most likely to die by suicide using a firearm are actually less likely to seek mental health care. They're less likely to disclose their suicidal thoughts if they do see a healthcare provider. And they're also less likely to have non-lethal suicide attempts by any method prior to their death by suicide using a firearm. So again, this is why we always say, I never saw this coming. So we need tools that focus on making people on a population level less capable on acting on suicidal thoughts that we might not even know exist in the first place. How do we do that? Means safety. And so that's that phrase I had in that early slide I said I'm going to come back to. And means safety means making items less deadly or less available. And so I want to talk for a second about what that looks like in public health issues outside of suicide. So you can see we do this a lot, actually, and we have a lot of success. You know about means safety, you just haven't called it that probably. And then I'll talk about how it's worked in suicide. But you can do this in a lot of ways. You can make the method less likely to cause the outcome you don't want. You can make the method more difficult to access. You can also make it less culturally acceptable. And the fact is we've done these to varying degrees with a whole bunch of different phenomenon in our country. So with HIV and AIDS, and again, I'm not arguing that means safety has resulted in all the success we've seen here. And I'm also not arguing that we've gotten rid of any of these problems, right? But we've made meaningful progress, and those create lessons we can learn for suicide. And so with HIV and AIDS, one of the ways we've had a lot of success in preventing new HIV infections is through implementation of needle exchange programs. And so the idea, why does this mean safety? Well, particularly in the 90s when these first came to play, the use of intravenous drug use using needles infected with HIV positive blood was a common cause of new infections. And so needle exchange programs do a lot of things, but one of the things they do is essentially take dirty needles off the market and infuse the market with needles that do not have HIV infected blood in them. And in doing so, the cities or localities that implemented these saw a dramatic reduction in new HIV infections. They also did not see an increase in intravenous drug use, so it did not cause the problem many folks feared. But by making the method less likely to cause the outcome happened less. What about lung cancer? Well, folks die by lung cancer more frequently than they die by suicide still, but they die by lung cancer less frequently than they used to. One of the things we did was just tax the heck out of cigarettes, right? You make them more expensive, fewer people can buy them. Fewer people can buy them, fewer people can use them. Fewer people can use them, fewer people can get cancer from them. Means safety. The third example is the one I think is actually the most salient and relevant for firearm suicide is auto fatalities. And if you go back to the early 80s, up to 60% of all auto fatalities were directly resulting from alcohol use. And we're extremely lax in the enforcement of drunk driving laws. And if you ask someone for their keys at a party because they had too many, you're more likely to get yelled at and then get support from their peers. Whereas now it's much more of a moral imperative not to drink and drive. And a lot of things have gone into lowering auto fatalities, both alcohol related and not, including making cars just so much more safe. But one of the things we did was the ad council just promoted messaging to change social norms and behavior. And so first you saw drinking and driving can kill a friendship, and then you saw friends don't let friends drive drunk. And then as auto fatality started to tick up in the early 21st century, they did some focus groups and found a bunch of young dudes who basically said, I just drive buzzed, not drunk. And so they had, well, buzz driving is drunk driving. And so we've changed social norms and adopted the model of designated drivers and messaged around this in a way that was salient and convinced people to change their behavior. So what about suicide? Well, it's the same thing. Mean safety has worked across methods across the globe, but it works most effectively if the method is highly lethal and it's highly common in a specific area. So the answer in one place isn't necessarily the answer in another. And so a few quick examples. Sylvia Plath in the upper corner there, famous novelist and poet, died in the mid-20th century in the UK by sticking her head in the oven. And to a lot of folks probably think, well, that is unusual. At the time, actually, it was the most common method in that area. And it wasn't because people were burning, it was the carbon monoxide rate was so high, people were quickly suffocated. And so at some point not long after that, the UK government thought maybe we shouldn't pump toxic gas into people's homes, and they detoxified it. And the suicide rate by that method dropped by 85 to 90%. What's important, though, is the rate by other methods stayed the same. And so the overall suicide rate in the UK went down by 30, 40% and stayed down. This shows that you swapping from one method to another is not how this generally works. When you stop someone from using a specific method, you save lives. In the bottom right corner, you see a farmer in Sri Lanka. Around the turn of the century, Sri Lanka was having a particularly tough problem with pesticide suicide. They banned the heck out of the most lethal methods or lethal brands, and the overall suicide rate in Sri Lanka went down by 50%. And then the example in the middle is a young service member in the Israeli Defense Force serving her compulsory military service. And again, around the turn of the century, Israel was noting that they were having a particular problem with young service members bringing their service weapons home on the weekend and dying by suicide. And they just changed the policy. So you can't bring your service weapon home on a weekend or holiday. You have to check into the armory. And the suicide rate amongst those young service members went down by 40%. So again, when you take the most lethal common method for suicide and you make it less deadly or less available, people die much less frequently. So what would mean safety look like with respect to firearms in the United States? One possibility is legislation. My lab is one of many who've done research in this area. We've tended to focus on things like background checks and waiting periods, which have a good amount of support from firearm owners themselves. And yeah, we found that these laws are associated with lower statewide suicide rates, with reductions from one year to another, and with a less severe suicide rate over time. But the reality is, in a lot of high gun ownership states, the socio-political climate is a very conservative one, and there's a lot of opposition to legislation. So if you rely entirely upon that, you're going to run into a lot of roadblocks in the areas that need it most. And so alternatively, a lot of folks have promoted the idea of safe storage, which I've spoken about quite a bit. And what I want to highlight is that these are not mutually exclusive options. You can pursue both. Pursuing one does not make you against the other, or does not imply you rank order one over the other. But the reality is, most people resist this, and they say, look, if somebody truly wants to die and you stop them from using a gun, won't they just find another method? And the quick and simple answer to that is no, actually they won't. But even if we ignore all the data showing that to be true, the reality is that they did find another method, it would be less lethal. And so there's a greater chance they would survive. And that's so important because amongst folks who survive a suicide attempt, 70% never attempt again and 90% never die. And so what that means is if you stop someone from using a specific method at a specific moment, there's a good chance you stop them from using any method at any moment ever. And so the ability to have a second chance matters, because if you don't stop them ahead of time and they use a method like a firearm, they're likely to die and there is no second chance. And so limiting access to that specific method, at least at times of high risk, becomes extremely important. So what gets in the way? I would argue it's bad salesmanship. Most folks like me, most scientists don't want to talk to anybody other than scientists. Or if we do so in ways that are inaccessible and make our findings sound irrelevant to the day-to-day life of the folks who are actually in need. And so this is obviously a busy slide, but here's the basic gist of what we found in some of our studies. The reality is most firearm owners don't believe firearms are related to suicide. And the ones who believe that the most strongly tend to store their firearms less safely and be less open to changing those methods, which means we have a messaging problem. We have very clear data that actually does not disrespect the culture of gun owners or the rights of gun owners. But because of the way we talk about it, it sounds like a gun grab, or because of our refusal to talk about it, nobody knows about the issue in the first place. And so why would they ever support the words of someone like myself coming from outside the community and talking about data? So what's the path forward? I'm just going to take a minute or two and then leave the rest for Q&A. The path forward involves, first of all, awareness, making sure that folks become aware of what suicide risk looks like, whether that's firearm specific or not, whether that's COVID specific or not. It's making sure, though, that that is voiced in a way that maps onto the needs of the communities that we're talking about. It means promoting safe storage of firearms. That could be through legislation, but can also mean through just campaigns promoting safe storage. And there's going to be different solutions in different places. And even within a specific place, different folks have different values and different reasons for owning firearms in different personal situations. And so the options they adopt are going to be different. And we need to be able to support individuals in their unique paths to safety. It's also a matter of research. We need the funds to pursue projects that better enable us to understand and decrease suicide risk. And unfortunately, for a variety of reasons, the funds have not been there, particularly with respect to firearms. And so there are basic questions that still need to be asked, and there are basic answers we have that need to be more effectively conveyed to the folks who need them. And that's going to come from research and from funding. And I think that that is quite possibly the most important step in all of this. So I'm going to stop here and leave the rest of the time for Q&A, but I want to thank you. I'm going to leave this slide up for a few minutes. It has contact info, my current email address, a couple of Twitter handles, and I should be easy to find. And I will turn it over to Katie.
Thank you so much for that presentation, Dr. Anestis. I believe it's the second time that I've seen a similar presentation by you, and I've learned so much more information this time, just the second time around hearing it, because there is so much research that you've done and that you presented here. So thank you. We have a lot of great questions from the audience, and I want to start with one that that dovetails with your prior last slide, which was about the need for more research. So the person asked, has the storage method been studied? For example, giving your gun to a trusted friend when feeling suicidal.
Yeah, so not as much as I would like to for a couple of reasons. So we do know that, like I said before, that unsafe firearm storage is associated with even greater risk than safe storage, right? But there isn't research out there showing, well, trigger locks versus cable locks, or gun safe versus lockbox, or does a biometric lockbox give as much protection as one that requires you to enter a combination, or how much safer is it to store the firearm away from home than to use a whole bunch of safe storage methods in your home? We don't have those answers. And so I'm doing a clinical trial right now of what's called lethal means counseling, where we work with service members about storing their firearms safely. And we're working under some assumptions that this is going to work, but that's one of those areas where, yeah, we need more research to make sure that what we believe is true actually is true, that not only can we change behaviors in terms of storage, but that those behavior changes actually save lives.
Thank you. One participant asked, is there an analysis into one's background and family when looking at the risk for suicide and suicide attempts? For example, if someone is experiencing immense pressure from parents or a feeling of never being able to live up to those expectations.
Yeah, so those two specific examples, not living up to expectations or feeling immense pressure from parents, you could imagine how that would impact things like perceived burdensomeness if we're talking about Joiner's model, right? So and it goes back to what I was saying before, that everybody has their own unique path, right? So someone's story of, I feel so much pressure from my parents and I can't live up to it, is different from someone else's story who's 65 years old and retired and saying, I don't feel like I did before and I'm not sure what I'm doing now, right? Those are two different things. And yet those folks might be experiencing that same underlying feeling of, what am I doing and how do I belong and how do I fit and is there a path forward for me? And so, yes, all of those individual stories matter a lot. And the trick is, there's no way for us to know every individual story and say, well, this one's the most important. But we have these overall categories that say, look, if someone is feeling this, that's alarming to me and I want to help them feel better. But yeah, absolutely. You can look at, even in studies looking at specific to that question, cultures where there is more, for instance, academic pressure on adolescents. And yeah, you see some risk of suicide, particularly at times related to, standardized tests that impact, do you get to go to the next level of education? And so, yeah, absolutely, those factors are relevant. But I think they all fit into that umbrella of people that there are things that cause people to feel those specific brands of distress.
And this is a really interesting question that may be related. If firearms are so important to suicide, why are the suicide rates in Japan and South Korea so much higher, even though they have almost no privately owned firearms?
Yeah, it's a really important question to consider because if there isn't an answer to that, it really sort of undercuts everything I said today. And my quick sort of snarky answer is, man, imagine how high those suicide rates would be in Japan and South Korea if they did have firearms, right? But the more reasonable response is it's a different suicide looks different in different places, and so the answer in one place isn't the answer in another, right? And so firearms are the highly lethal, commonly used method in the United States, and addressing firearms here would have a real impact here. And that doesn't mean banning them, right? That's not overturning the Second Amendment, but limiting the ease with which suicidal people can access them in the United States will save lives. But those same efforts won't have much of an impact on Japan and South Korea at all because so few people are accessing them, right? And so the idea is there's a cultural script around suicide. There's a woman named Sylvia Caneto who's done amazing research on this. It says what suicide means differs from place to place and culture to culture. And the idea is to find the method in a specific area or culture and address that because it means something different to them or it looks different in their heads than it does here. And so firearms don't cause suicide out of nowhere. They just make suicidal folks more likely to die. And there are other things that can do that too. But the problem here is firearms. The problem in Japan and South Korea would be something different.
When you had the chart up, when you were kind of comparing the rate, like the suicide rate compared to like auto accidents, fatalities in the United States, do you know what the top fatality is and how suicide compares to that in the United States?
Geez,
The top cause of fatality.
I should that's a really great question. That's a really simple thing I should just have an answer to. Because I don't want to create the impression that suicide has a more outsized role than it does. So my point in the way I had it was to highlight this is more common than a lot of things you think about, but it isn't to create the illusion that it's more common than everything else. Suicide is the 10th leading cause of death, not the first and not particularly close to the first. So I don't have a specific number, but my argument isn't that this is the biggest cause or most common cause of death in the United States, just that it is one of the least spoken about relative to its scope. If you look at how much funding is applied to the other top 10 causes of death, we are disproportionately underfunded on suicide because it has been something we've largely sort of pushed under the rug. And so I sort of framed that slide in a way that emphasized how big it is, but I don't want to be misleading in doing that and accidentally overemphasize it. So I know I don't have the specific number, but your caution is warranted and your point is taken.
So talking a little bit about context and cultural context, thinking about like demographics within the US, what are the racial demographics of those committing suicide with firearms?
So with firearms, anybody can do this, right? So the risk of having a firearm in the home is the same regardless of who you are. The issue is more that the firearms tend to be more readily accessible in the homes of particular groups. And so you see really highly elevated rates of firearm suicide amongst men in general, amongst white men, amongst folks in what you would refer to as honor cultures, particularly in the South, amongst service members, amongst veterans, amongst older adults. So yeah, but that doesn't mean that firearm suicide doesn't happen amongst adolescents, right? And so, or that it only happens amongst white men. And so, in framing those demographics, we can say this is where it happens the most frequently or at the highest rate. But my concern then becomes if we become so hyper focused on those groups, then we're probably furthering the disparities that already exist by then not focusing on groups at risk whose the numbers might not be as high, but whose deaths are just as important, right? And so we want to save as many lives as possible, but we want to have equity in how we do that. So we're not only saving a particular type of life. And so sometimes that's why, in some ways, I kind of underplay who's most at risk when I talk about this, because I want us to think about solutions for everybody and not solutions for one particular group or a couple particular groups. But yeah, no doubt there are demographic groups most likely to fall into this category.
Thank you. And we've had so many questions come in this last part of the discussion, so we won't have a chance to get to all of them, but several people have asked what you believe about folks who have either presented suicidally in the past, whether they should have firearm safety training, and whether they should be allowed to own a gun.
So there's a great researcher at Duke named Jeffrey Swanson who's done a pretty compelling line of research that shows that when you do or you frame legislations focused specifically on preventing access in folks with mental illness, it's not effective. It only works when you do it at a population level, and that's for a couple of reasons. When you zero in just on folks with mental illness, the concern then becomes not that you're going to save the lives of folks with mental illness, but you're going to make them less likely to seek help because then they're going to have a scarlet A, right? And so what we don't want to do, and again, because like I was saying before, we're so bad at knowing which folks are going to die by suicide. In fact, mental illness is a terrible predictor of it. Even suicidal thoughts is a terrible predictor of suicidal behavior, and it's one of our best ones. And so if we zero in just on those folks, we're going to miss the folks. I think what I'd encourage folks to do is realize that if you close your eyes and picture what does suicide look like, that picture of that person in your head is probably fundamentally removed from the reality of what American suicide typically looks like. And so if we base our approach on what we see in our head, we're going to miss what we're actually seeing in the data. And so what I'd rather do is a population level, assuming that I'd love to change cultural norms and make everybody open to talk about their feelings and seek evidence-based care. I just don't think that's going to happen very quickly. And so I want to essentially take a fluoride in the water approach and say, I want to do sort of reduced cavity vulnerability for everybody if they drink water, right? And so I want to lower the risk for everybody. And the reality is it's never going to hurt somebody to have less ready access to firearms and lower their suicide risk. But it is going to hurt someone if we just overlook them as someone who might benefit from that.
So we won't have time to get all the individual questions, Dr. Anestis, but how can people get more involved? People have so many questions for you. They're clearly very interested in the Gun Violence Research Center from looking at the questions as well as suicide and firearms. How can we get more involved?
Yeah, so the quickest answer to that is to go to the website for the center, and that is gunviolenceresearchcenter.rutgers.edu. And from there, you can sign up for a newsletter. You can get onto the mailing list. You can email us directly. You can donate. There's all sorts of things you can do through the center that way. Obviously, I haven't started yet, and I won't for over a month. And so there's some transitions and changes. But throughout all of that, I'd also say reach out to me directly. Reach out to the assistant director, Thurman Barnes. We're happy to be involved. I love when there's energy around this topic or related topics. And so I think it's just a matter of reaching out, getting to know us and letting us hear sort of why this issue is important to you and how we can be of benefit to you.
That's all we have time for today. Thank you, Dr. Anestis, for sharing your time, your wisdom and expertise with us today. Thank you to all of our attendees for joining. We hope everyone stays safe, healthy during this time, and we hope to see you in future webinars. Thank you, everyone. Have a good afternoon.